She's been with the department for almost 10 years. She has a PhD in clinical psychology, but more importantly, she works at the interface of clinical practice and research. She's a certified clinical psychologist, has had her own small business, I guess, counseling families and individuals. At the same time, engaged here at Rollins and School of Medicine on projects that she's going to talk about. She's the expert. I jokingly always use she's our resident mental health expert. And we also, when we all need help, we're like, Rachel, what do we do? But it's great to have Rachel as part of our community. Done work globally. We're part of some large projects that involve populations in different settings, but also right here in our own backyard. As you all know, she started working on this before COVID, before mental health all became fashionable, I guess is the word, if I might say that. So Rachel, thanks for doing this, and I'm sure others will be interested. Some interesting opportunities.
Yeah, thank you, Usha.
Yeah, you're welcome.
And those online, could you all hear Usha okay?
Your hands up.
Yeah. Yes, we were able to. Thank you.
Yes. Awesome. Great. Thank you.
Yeah.
Oh. Sorry, I thought I left the meeting. I didn't.
Okay.
All right. Well, thank you guys for being here. And we might get some folks who join us who were in a new room today. So we might get some people kind of
Struggling.
coming in. And I know there are people joining online. So thanks everybody for coming. I am going to do something a little bit different and with this time today. So Usha kind of alluded to some of the work that I've been doing, but I'm going to spend most of the time today to talk about work that I'm hoping to be doing in sort of my next phase or time here at Rollins. As Usha mentioned, this July 2024 will mark 10 years at Rollins in the Global Health Department. And I have, during that time, I've spent in the community in clinical practice, serving the population I'm going to be talking to you guys about today. I've also been here in the Global Health Department, teaching, mentoring students, collaborating with colleagues, but I've also been a student of sorts, I would say, a student of public health, a student of global health and global mental health. And so what I'm going to be talking about today is really a culmination and an integration of that work over the last 10 years and what I'm hoping will really come together in some new work that I'll be presenting to you guys at the end, some ideas that I'm hoping to share with you all. There's an real opportunity here for, I think, especially with the population that I serve, and especially in Atlanta, to integrate some global mental health models into really improving some of the systems that we have. And so I feel really grateful to have spent my time. This is not where I thought I would be as training as a clinical psychologist. I didn't imagine myself in a school of public health, but I'm just grateful that this is where I landed. And I think it's really, I'm excited to share some ideas with you guys today. So I'm going to lead you through the context of why I think this population is so important to invest in, for not just for me, but for all of us perhaps, and then end with some ideas that I'm formulating into some specific aims that I'm hoping to submit later this year. All right. So we're going to brainstorm, we're going to talk out loud. If you have questions, if you have feedback, this is for those in person, also online, please let me know. All right, so whenever I'm having these talks, I always want to talk just a little bit briefly about what do we mean when we're talking about psychosis? And it can mean a few different things. Generally speaking, it's a set of symptoms, right? So any of us under the right conditions can experience psychosis. When you're sleep deprived, when you're under extreme stress, when you're involved in those funny videos online of people getting their wisdom teeth taken out or coming out of anesthesia. But when we're thinking about the symptoms of psychosis in a really consistent and more intense way, we're talking about a cluster of experiences that people have that are really affecting their ability to engage in the world meaningfully, to engage in the reality that the rest of us may share. And it's really disrupting one's ability to act effectively in the world, experience a sense of agency, and making it just really difficult to function. I think another component of psychosis, come on in, don't be shy. Another important component of psychosis is that it is it's a chronic illness, and chronic in the sense that it is something that folks do often need to manage for the remainder of their life, either with medication or with therapy or some combination. And in small minority of cases, with like nutrition and physical activity. I think another important component is that many illnesses that we associate with psychosis, like schizophrenia spectrum disorders, start between the ages of 16 to 24. When we're talking about chronic illnesses, we're really talking about a lifespan. And if we're talking about illnesses where people don't have early and effective treatment, we're talking about a lifelong experience of distress and often a lot of torment and fear. And so this becomes really important to be thinking about how do we engage early and how we engage effectively so that folks who are living with these experiences can actualize recovery. And I'm going to talk a little bit about what that sort of phrase means. So I might be using the term psychosis and schizophrenia spectrum disorders interchangeably today, not on purpose, but I really am kind of talking more specifically about clinical diagnoses and not some of those kind of fleeting experiences that, as I said before, any of us can have under the right. I'm going to move this over so I don't have to keep so far walking. So in case you're wondering, schizophrenia spectrum disorders are a global issue. So they are something that no matter where you go in the world, there is some description or some version of those symptoms that I spoke to you about here or shared with you just a moment ago. What you see over here on your right is the front page of the World Mental Health Report, the most recent version that came out in 2022, that really gives us an overview of what the kind of landscape of mental health experiences are globally. And so if we look at if you take a gander at it, if we look at the information that's specific to schizophrenia spectrum disorders, there's a lot to see and a lot that we're reminded of. So this is something that affects 1 in 200 adults globally. So no matter where you go in the world, we might call it different things. It might be expressed differently. It might be described differently. It might be treated differently. But we do see some consistency in the kinds of experiences that people are having associated with those symptoms that I mentioned before. I think it's safe to say that it's probably the most severe and debilitating mental health disorder. That may not be surprising to you. You probably already have your own ideas and biases about what it means for someone who's living with schizophrenia or has that diagnosis. Please feel free to come in. Grab a seat, or we can just hang on the floor. We can just have a little hang. I want to highlight in the acute state, because we all probably have our own ideas about what it means when we hear the term schizophrenia. And there really is an opportunity here for recovery. So in the most acute states, it can be severe and debilitating. An acute meaning in the context of an episode or when someone doesn't have access to the treatment that they need. But there are enormous opportunities for recovery, which we'll talk about today. Folks living with schizophrenia spectrum disorders have significant rates of early mortality and significant comorbidities from preventable causes. Most commonly things like cardiovascular disease and diabetes and other endocrine-related issues. And it's really important to think about preventable. This is not uncommon when we talk about other non-communicable diseases. But when we think about the ways that folks living with schizophrenia are affected, we can imagine the compounding effects of living with the kind of symptoms that I mentioned to you, as well as other physical or preventable diseases that we just talked about. And if we think about that chronic experience of the illness, we can imagine the compounding effects of decades of living with these kinds of experiences and the compounding distress related to being able to try to care for your physical health as well as care for your emotional or mental health. It is by far the most costly mental health disorder per person per society. And that's for a few different reasons. One, we'll go back to the point before about comorbid experiences. So people who are living with schizophrenia spectrum disorders are living with other comorbidities, and that becomes really costly to manage those experiences along with your mental health. When folks don't have access to early and effective treatment, they're also using the most costly mental health services. So they're using emergency room visits, which are incredibly costly to manage your mental health care. They're having difficulty getting medications that are most cost effective. They might be utilizing different kinds of specialists when we could be offering more effective suite and cost-effective services. It also becomes costly when we think about the financial instability and burden that a person living with this illness has. They're often, if they don't have access to effective care, not able to work, not able to care for themselves. And so it becomes costly for the person, becomes costly for families who are maybe also not able to work in the way that they might typically be able to work. And then it does become a cost on society where folks are utilizing resources and not able to kind of pay back in the way that we all normally do. So it's quite costly in terms of those financial burdens. And I feel pretty confident in saying it's probably the most stigmatized mental health condition, perhaps even one of the most stigmatized health conditions by the public. If you think about the first thing that comes to mind when you hear the word schizophrenia or someone living with those experiences, you might notice your own biases that come up. But it's not just by the public. It's very stigmatized in medical and mental health spaces as well. People have biases about what folks living with these experiences are able to do, are able to accomplish, the level of recovery they're able to achieve. There are biases about threat, biases about how threatening or dangerous these folks are, despite the fact that we know these individuals are much more likely to be victims than they are to be any kind of perpetrators of violence. The world is very, very scary for many of these folks. And related to that point, it's also highly miscommunicated. And this is, one of the things that is really, really challenging is we have these sort of inadvertent or themes kind of floating around that are really sort of stigmatizing and oppressive to this population, terms that we all use, right? But that really communicate how we think about folks living with these experiences. And with this, I think, personally, I feel like the folks living with these experiences offer the greatest opportunity for recovery. If we imagine what it looks like when people don't have what they need, you're not having early and effective treatment, you're living with really tormenting hallucinations or delusions, you have significant cognitive impairment where you're having trouble with decision-making and problem solving and judgment and emotion regulation, and you're feeling sort of disorganized out in the world, that the world around you has changed so significantly that it feels really scary. And then we imagine what it looks like when people do have the opportunity to recover. They have early and effective treatment. They're living independently. They're working or volunteering. They're having relationships. They're having intimate relationships. They're having families. That gap is pretty enormous. And in that, it is incredible opportunity to shift and modify and really invest in what we can offer folks living with these experiences. So it's not going to be surprising to you. I've already kind of alluded to this in a number of ways, that there are benefits of early intervention and effective treatment. So kind of across the board, folks who are really receiving not just early treatment and early meaning, either in the context of a new episode for a young person who's experiencing this for the first time, or perhaps someone who's had repeated episodes, but there's a new onset of an episode. We want to intervene as early as possible to minimize the impact on functioning, to minimize the impact on relationships or other things that people have going on, and also to minimize the impact on the brain. A psychotic episode, you can kind of think of it as a traumatic brain injury. So it really does take some time to sort of recover. And so we really want to minimize any of those kinds of impacts. So when people have early and effective treatment, consistent reports of higher subjective quality of life. So people are experiencing their lives more meaningfully. We see improvements in those comorbidities and also early mortality rates. There is a recovery of cognitive functions and abilities. So the brain is able to recover, and it's a pretty incredible thing to see. The more episodes that someone has and the longer they last, it can be harder to recover. So that's where that early and effective intervention becomes really, really important. You really want to give folks that opportunity. We also increase that financial stability that I talked about and reduce that burden. And we decrease the rates of other psychosocial stressors that just make life much more difficult and can compound the stress and trauma that people are already experiencing. So in the field of psychology and psychiatry, you probably, if you're in sort of having dialogue about mental health, you hear this term recovery thrown around, but it really is a formal model that we do look toward when we're thinking about clinical practice. And it includes the components that you guys can see listed there in some form or fashion. And what you probably notice that you don't see here are things things like symptom reduction, getting rid of experiences, decreasing symptoms, decreasing severity. We do want to invest in those things, but those are a bit more unpredictable. Can't be sure when things are going to happen or how long it might take to recover. But what we can do is promote resilience, help promote people rebounding from episodes, creating buffers and foundations so that when people perhaps do have acute episodes or even severe, more severe long-term episodes, that they do have those foundations of the things that are helping them return to a life that feels meaningful. And we can see here, if for those who are familiar with the WHO's definition of mental health and well-being, you'll recognize that a lot of these components are part of that definition. Someone's ability to be able to cope well with the stresses of life, to be able to contribute meaningfully to one's society, in whatever way that looks like, to be able to hone skills and be able to develop skills, refine skills and things that you care about. So these are the kinds of things that we're really invested in when we're thinking about helping someone through recovery, not just schizophrenia, any other mental health condition. But I think these become really, really salient for folks like schizophrenia or living with schizophrenia, because these are the kinds of things that become much harder to achieve and harder to maintain. With that in mind, let's just take a step back to that treatment conversation, okay? So we do have effective treatments. So I've been talking about early intervention. I've been talking about effective intervention. I know you're sitting there wondering, like, what is, oh me, well, let me tell you. So we have some, I'll kind of cover these briefly, but we do have gold standard methods of care for folks who are living with schizophrenia. So one in particular is something called the coordinated specialty care model. This is for young people who just have their first psychotic episode. There's a really specific suite of services that we want folks to have to help them recover from this really traumatic experience, to really kind of help set the narrative for what does this mean about you? What does it not mean for you in your future, and really help craft that, and then help people engage or re-engage with things like school, work, living independently. Because if you'll remember, that onset is 16 to 24. And if you guys think about where you are or were in that age range, there's a lot happening there, right? And so we want people to really be able to engage effectively in that developmental stage. We do have evidence-based psychotherapies. So we have therapies that have shown to be effective to help folks through these pretty traumatic experiences. And we have effective medications. So historically, medications had a lot of side effects. They were really hard to stay committed to, but that really has shifted. We have effective medications so that people are able to find regimens that work for them, allow them to engage meaningfully in the world without feeling this sort of the heightened effects of medications that we saw historically. And we know that there's robust evidence for family support. If the family is involved, whatever that family looks like, family of origin or chosen family support really promotes recovery and resilience when you've got those folks that are there, that are going to be there as you sort of move through this roller coaster of experiences. But I think what we're noticing is the stuff that we have is just not really doing the work that we want it to do to help people really achieve that full model of recovery that I was showing you just a minute ago. This is a paper that actually just came out, and I'll just read, one of the points that really stood out to me is that even under optimal conditions, treatment alone will never be sufficient to reduce the global burden of mental disorders. So a shift in focus from treatment to prevention should be promoted at the central level in the form of legislation, policy formation, and resource allocation. This paper does talk about schizophrenia specifically, but also just generally thinking about what are the kinds of things that we need to look to really ensure that we are meeting the full comprehensive needs of folks who are living with these experiences. And these ideas of legislation, policy formulation, and resource allocation really get to those areas of systems. It's systems related issues. And that's where we're going to be kind of moving forward today. So as you can imagine, there are some challenges to really effectively serve this population. So let me just pause here, and I'm curious from you guys, what do you think might be some of the challenges, given what I've shared with you already? No right or wrong answers. Anything you feel comfortable sharing, what might be challenging? Yeah.
Adherence to treatments when there's additional barriers, whether that be the condition itself or access to care.
Okay, yeah, adherence. So whether it's because of the symptoms you're experiencing or just other kinds of systemic or sort of environmental physical barriers, whatever those might be. Other things, yeah.
I would say stigma, being able to access care freely without feeling stigmatized.
So stigma. So yeah, where can I go to sort of safely talk about this experience where I feel like someone's going to understand me, either not be dismissive, but also really listen and understand what it is that I'm looking for and what I need, and not be having these sort of biases about what recovery might look like for me and what I'm able to achieve. Or in certain spaces, more extreme stigma, things like isolation, or, we've got lots of different ranges of stigma. Here in the US, it's a little bit more formal is not the right word, but it's not as obvious. But there are other places around the world where the stigma is much more obvious, where you are very much sent away in a hospital for the rest of your life to a prayer camp. Yeah, all right.
So if you're trying to move towards prevention, you haven't told us anything other than the age category about which groups might be at increased risk and therefore might be better targets for prevention activities.
Yeah, I haven't done that. My conversation today isn't as much about prevention in that formal sense, but I think what we can think about are how some risk factors for folks for developing this. This is a heritable illness, so many people who are developing this experience or schizophrenia, there's a genetic component, but there certainly are risk factors, things like trauma, things like stress. And there are certainly things that can mitigate the experience of someone's first episode. And those are things like access to care. How quickly can someone access care? And not just access any form of care, but that care where someone is sort of specialized in working in this way, or has knowledge about what are the most effective or most helpful responses, and not just medication and psychotherapy, but things like conversation and things like support. So in terms of preventing the illness itself, that's a little bit more of a difficult question, but we can certainly mitigate the impacts of either the onset of new episodes for someone, like if someone who's never had an experience before, or the onset of a new episode for someone who has had episodes. What I'm going to be talking a little bit about today too are some systemic shifts that I think we can make, and I'm going to be talking specifically about the Atlanta context that I think can also relate to that question of prevention, because the earlier someone can start to have conversations about these experiences that they're having, that they're not sure what they are or what they mean, or is it okay, the earlier that we can start to have those conversations, even if it's not with medication formally, then we are able to better predict a better prognosis for folks. Did you just want to add?
Yeah, for this question, I think hierarchy of needs can be challenging, especially like on a global scale. If hunger is the immediate need, then that might be the focus and like the funding. And then also I feel like religion can be a barrier as well. It could be like an explanation for the manifestation of their psychosis, or also a barrier in treating it as like some.
So you're talking about a lot of really important things and a lot of really important considerations. So I want you to bookmark that. Bookmark that.
One is the same.
Huh?
It was the same questions. So
It was the
same answers.
Same answers. Okay. Thank you guys for offering in the chat. So I'm not going to review this whole schematic here, but this is just to kind of answer the question and more, or to, I guess, kind of address this, is that it's quite challenging for many of the reasons outside of what happens in the clinical office, right? Is it the right medication? Is it the right therapy? That there are a constellation of issues that are really making it challenging to really effectively serve this population. This is really referring to folks who are living with mental health conditions generally. This is not specific to schizophrenia spectrum disorders, but it gives you an idea. And for folks who are already familiar with the socio-ecological model, this is not new to you. But to give you a sense, or us to be able to just really kind of come together on this point of what are all the different layers of potential barriers, or I'll say potential opportunities that we have to really think about in terms of how to improve access to early and effective intervention. So just to kind of move us to to this page. So here's the thing, we know what works in the clinic, right? So someone comes into my office, myself and the folks that I work with who serve this population feel pretty confident in our ability to have conversations that we think are helpful, to find the right medication regimen that is going to work for somebody and allow them to keep taking their medication because they're going to have reduced side effects and be able to engage in the world. But we know that there are gaps. We know that that's not really covering everything that this community and this population needs. There are, as you guys alluded to, there are a lot of barriers to getting that early and effective care. And we know that for this population, when there is a longer duration of untreated illness, there's some really significant impacts. Disruptions in important life events that are happening, disruptions in cognitive impairment that can be much harder and much longer to recover from. So it really is important that we're really reducing those barriers to care as quickly as possible for folks. So there's some of the gaps and some of the hardships are that the early and effective treatment is there, but you have to find those folks that are able to have those non-stigmatizing conversations and are able to, are professionals that are able to have knowledge and work in this area. And if you can find a person, then you have to figure out how to get there. So where is it located? How close is it to you? You got to figure out how to pay for it. We've already talked about the burden, right, of what it might look like to live with these experiences. And you have to do this pretty often. So therapy is like weekly, every other week. Psychiatry appointments, talking like monthly, maybe every other week. And you have to do all of this while you're living with experiences that are pretty tormenting and pretty distressing. There's a lot of work that has to go into getting the care that you need when the world feels really, really threatening. And I think that's a lot to ask of the populations living with these experiences. So let's move a little bit specific. Let's move specifically to Atlanta, because that's where we're all sort of working and playing, and where I'm, really hoping to invest some of the work that I'm doing. So let me just tell you a little bit about what that looks like. So if we think about what we've got already here to meet the needs of this population, we have 2 clinics already for adults living with psychosis. They're based at Grady. You'll notice that I've underlined adults because, as we mentioned before, some of these experiences happen before you reach the age of 18. So if you were younger than 18, we don't really have anything specialized for you here. But if you are 18 and over, we have 2 specialized clinics that are downtown at Grady. In addition to that, and these are folks that provide psychiatry, so medication, they provide some other maybe case management services. We have a community of outpatient specialists. I'm one of 6 in the Atlanta area, which is not a lot, right? If we think about Atlanta as like the broad Atlanta, so like when people say they're from Atlanta, but they're really from further out, talking about those spaces too. There's 6 of us that serve this population in outpatient psychotherapy. There are probably more that do this work, but in terms of like formal folks that specialize in this area. And the systems that we do have, or at least the clinics that we have, they are embedded in academic settings. So they're invested in rigorous research and really supportive of clinical trials. So the outpatient clinic at Grady is overseen by Emory and Morehouse Schools of Medicine. They have a number of NIH funding, NIMH funding, SAMHSA funding. So there's a lot of what's really good infrastructure there, it seems like, to support that work. But again, as I alluded to earlier, there are just really significant gaps. So we have anecdotal evidence from the folks that we serve that there are issues in the services, the suite of services that we have available for them. We notice issues in continuity of care and transitional care, people being able to both recover from an episode and be able to then move toward increasing levels of independence, which is ultimately what we want for folks and what they want for themselves. And then programs that are really intentionally focused on that recovery model that we talked about. So we've got pieces, we've got ideas, but it's not really it's not sort of fully formulated in the way that we would like. And I say anecdotal evidence because we're also not measuring, and that's a big problem. So these are things that we hear, these are things that we're having conversations about, but we don't have outcome data that is really following that. We also have objective evidence that services are just difficult to access and maintain. And I say objective, I don't know if this is the really the best word, but the fact of like where the location of the clinics are and how easy it is to access for most people who might need it. It's in a really busy area downtown. There is a MARTA stop there, but 5 Points MARTA station is very, very busy. And if you're living with active experiences of psychosis, that can be a very overwhelming place to be. Has anyone been to the 5 Points MARTA station? Yeah, it's pretty overwhelming, right? It can be, again, difficult to navigate. It's a particular area of town that can be difficult to navigate. And so we know that even if you can identify the practitioners, you can identify the clinic, it can still be difficult to get there and to really sort of physically engage with the services. And this is where we really start to think about this idea of community-based care. So if we think, community-based care is a term that we use a lot, but by definition, it just really means care that's not in a hospital. And so we can say that about a lot of services. That doesn't necessarily mean that they are community-based for folks that need them. And so there's a lot of room for gaps there, or a lot of room for opportunity. And I think this is where we're bringing in global mental health models becomes really, really important, because this idea of what community-based care looks quite different, and it's much more a conversation or an idea around community-informed care. So this is where, for me, things really start to coalesce. As someone who is living in the community, serving the community as a clinical psychologist, focused on what happens in my office and doing really good care there, but really recognizing that we're really missing there are a number of gaps for this population, and trying to think about what are the most effective models or the most effective ways to address that. And in my time here, and I have a class that I teach in the fall, Introduction to Global Mental Health. And so through my preparations for those classes, through collaborations with colleagues, through really diving into the literature and just learning so much about what people in different places around the world are doing, just seems like there's a wealth of opportunity to incorporate those models. For those who are already working in public health and have been for a long time, that probably seems like many of these things will seem like an obvious fit, but it really is something that feels quite new for, at least here locally, the way that our system is designed here to serve this population. So it becomes really unique about thinking about these models. I think there are two things. One is that when we look at global mental health models, I'm kind of using this as a broad term, but if we think about global mental health models of care, we see consistent innovation in those programs. And there's a couple of reasons for that. One might be out of necessity, right? There might be fewer resources, having to get really creative with resources. And so thinking about innovation comes naturally from those kinds of spaces or those kinds of needs. I also think innovation is important because people really, in many communities around the world, are just thinking differently about investing in the people that they are immediately surrounded by. So that just really influences the designs of programs, which is a different kind of investment in who we think about, who we're caring for, and how we care for them. There's also less emphasis on non-medical interventions. So first line of treatment isn't always medication. It may not always be psychotherapy. It's much more relational. It's much more community-based. It's much more looking at other kinds of opportunities that help someone really be engaged in the community that they're a part of in an effective way. So I think there's a real opportunity here to bring in some of those ideas into some of the problems or opportunities that we see here. So here are some of the major models that I think are really relevant to the conversation. And I'm going to break these down, each of these down briefly. The first one a little bit more so. But let me pause here and just see questions or anything so far. I can talk like a freight train, so I can just keep rolling. Okay. So the mental health and psychosocial support model is probably the most common model that if you have done any sort of reading into the global mental health literature before, looking at any kind of intervention and prevention programs, this is generally the model that you're going to be seeing. And this is the model that's used both for humanitarian emergencies or also just for generally designing programming. And this is where your bookmark becomes really relevant, because it's thinking about how do we invest for folks. Also, Ari, gets a little bit to your question. which is where are we putting our emphasis? And what is it that we can do, not just to help during acute situations, but what can we offer so that generally speaking, people are feeling supported in whatever their health needs might be, so that when an acute experience does come on, that they're not also compounded by all of these other needs and stressors that they might have. So there's a real emphasis in how are we just generally taking care of our community and our population. Now, the designs might look a little bit different, or the details, depending on if you're looking at a model for humanitarian emergencies or you're just looking for a community mental health model in a particular context. But generally speaking, you can see that there is really a shift in where we're putting emphasis on the things that really create, support one's ability to care best for themselves and to really engage in the world in a meaningful way. We know those create buffers. We know those create resilience. We know those can mitigate the impact of acute stress, whether that is a psychotic episode in schizophrenia, whether it's an episode of depression, whether it's a traumatic loss, whatever that might be. And then really spending less on the things that are most costly, which is our costly practitioners, costly clinics, and really reserving those for really acute experiences or acute settings, and really investing more in things that might minimize the likelihood of those really acute or severe episodes. This is another, this kind of breaks this down a little bit more. This is also from the World Mental Health Report that talks a little bit in a similar way about how we might look at this for folks. And so again, it's really about investing in what are some of the things that people, whether or not you have a mental health condition, just might need to engage fully in the world, engage meaningfully in the world, really work toward achieving that definition of well-being, and thinking about what some of those risk factors might be. Minimizing stress, minimizing engagement with high-risk situations. We know trauma, at least it can be a predictor for schizophrenia, or it can be a risk factor. Helping manage kind of smaller blips as they come, right? We all have those. We have bad days, bad weeks. And so if there were, for folks who are more vulnerable to those, how do we help folks manage those in an ongoing way so that they're less likely to develop into things that need a lot more care and that are a lot more difficult to access? I would love to say, and I think in some ways we can say that we have how to say this? I think we can have easier access here, relatively speaking, but it still doesn't mean that it's easy. It really can still be quite difficult for people to access the kind of specialized care that they need, regardless of what it is that you're looking for. What this model also emphasizes, and that's something that we don't see as much of here, but there's robust evidence for in global mental health models, is relying more on our community members. And so people who are really living in the communities where, are living in local communities and are really engaged in investing in mental health care. So in global mental health models, we might call these, we call this task shifting, where this might be community health workers or lay health workers who are trained to provide some brief interventions, but they're embedded in the places where people are living and working, and they're trusted, they're rooted in the community, and they are much easier to access, they're much more readily available, and they are not as costly and as what we might identify as more specialists. So we talked a little bit about that idea. Some other ideas that we really can kind of think about are integrated healthcare models. So thinking about how do we create systems and spaces where people are able to more readily access the services that they need. So thinking about embedding mental health services into primary care services, thinking about mental health care in schools, even into ERs, having sort of specialty services for psychiatric emergencies. We actually have that at Grady. But really maximizing or broadening the opportunities that people have to access the care that they need so that we are minimizing those episodes that are happening or mitigating the impacts of those episodes that are happening. Thinking about universal healthcare support, so eliminating payment barriers. Today's actual world is Mental Health Day at the Capitol here in Georgia. So people are at the Capitol today lobbying for those parity, that parity in insurer payment for mental health services. And so this, you might be thinking about, well, what is, how might I be able to engage in some of this conversation? And that's really thinking about, some of the ways that we all can, I guess with voting really is what I'm trying to say. Thinking about where you're putting your vote. If you're thinking, I'm not going to be a clinician, I'm not going to probably engage in mental health care. Well, you can vote on things that would make this a bit easier for folks. And then coming to this idea of community-based support that really is community informed. So thinking about how do we increase proximity and access? How do we make it as easy as possible to get the care that you need, and broadening the places and spaces and people where that service can be offered. We really need to understand the needs of the people that are living with these experiences, bringing those conversations to the table, really inviting people to tell us, or whoever the stakeholders might be, what is it that you need? We think we know what you need, but you need to be part of that conversation. Collaborating with local leaders to create community spaces for care. So care doesn't always have to be healthcare in the formal sense, medication and therapy. There are places where people feel like their health is getting served in other ways, in faith communities and other community organizations. There are lots of ways to think about addressing health, where people get health benefits without those formal medical interventions. And we can think about, again, making services much more accessible to the people that need it. Right now, we have a system that is much more convenient for the people doing the serving than it is for the people that need the service. And I think where those global mental health models become important is because that is a bit more of a shift. It's about creating opportunities for health in the spaces where people are, recruiting the help of the people that are living in those spaces, so that we really are making it much easier to access the care that you need. For this population and the vulnerability, this becomes increasingly important because of the risk of living in a more chronic way with the symptoms that we talked about. That kind of brings me to, all of that brings me to kind of, where it is that I'm kind of putting my information, my resources and my ideas, is thinking about, with what I know in my clinical space, what are the things that I know from the folks that I'm serving, and how am I really integrating that with the work that I've been doing here at Rollins? How am I bringing these worlds together and thinking about how to serve, using the opportunity of the information that I've been able to learn and gather and investigate and share. And so collaborating with colleagues in the School of Medicine to really formalize a proposal or a project around assessing the effectiveness of our local psychosis programs to meet the need of our population here. We recognize the need, we recognize gaps. And so really thinking about using some methodologies that we're often not looking at as much in sort of the in our local health systems here, but really thinking about really intentionally determining the needs of the folks living with psychosis. Wondering about if we're meeting their needs, asking them, what are the gaps? How are the needs different depending on what stage of illness you're in? Is our system flexible to meet the variation of the needs that you might have? As your needs change, as you begin to recover, or as you begin to have more challenges, do you feel like there's flexibility in what we're able to offer you? Really identify that full suite of stakeholders. So talking both to the service users, but also ensuring that our clinicians and our case managers and all the staff that's trying to really support these individuals, what are the needs of those stakeholders? What is it that you need to really fully invest and care for this population? Burnout, mental health burnout of mental health clinicians is not new. We learned a lot about it during COVID as people were really being tasked with caring for folks who are having increasing mental health needs. We really need to be taking care of the people who are offering that care. We don't fully know who's getting access to the specialized services that we offer and how. We're not fully sure how they're finding us and how they're getting to us. We really need to understand those mechanisms so that we can increase those routes for more folks. And then we really need to determine the services and supports that are needed for that holistic recovery-oriented care. If we really want to engage with that model that I showed you and that we really invest in psychiatry and in psychology, we need to think about what are the services that allow us to actualize those indicators. And then discover new opportunities for service provision. So pulling these together into hopefully some more specific aims later this year. Already have some conversations with NIMH and program officers there. Already have some interest from local fund donors who have their own personal interest in this population because of personal experiences with someone in their family. And so really thinking about pulling together this information of the clinical needs that we know are there and using what we feel are really innovative models. And they're innovative to folks who may not be living in the public health world. And we really feel like they can meet some of the gaps that we're seeing. So thank you guys for listening and letting me share a little bit about another area that I'm passionate about and how I'm really kind of bringing this together. And open to any feedback and questions, and I'll report back after we get fully funded.
Questions?
Yeah.
This is about the California mental health law. I don't know about it, but it's like if somebody notices or sees someone that they think is like experiencing some mental illness, and then they like held for 3 days to like get treatment. And have you heard about that?
I haven't heard about that specific one. We have, most states have.
Oh, okay. So does that have like any, like, is that effective?
Can you repeat the question for those on Zoom?
Yeah, so the question was, someone's referring to the California law for involuntary commitment, where if you have concerns about someone harming them, being a risk to themselves or someone else, you can involuntarily admit them into a hospital for 72 hours.
And I think it's like mostly for homeless people is what I was, because I know there's like big grafting, but like this one I think is concentrated on the homeless.
And the question was, is that effective? I think that's a big question. It depends on first who is it effective for. And I think for someone who is really in acute distress and acutely at risk of hurting themselves or someone else, either because they might be having thoughts of suicide or might be, having really scary thoughts that might lead them to take action because they're feeling really threatened. It can be effective in sort of really immediate, like helping them be in a safe space. But if you're asking about effectiveness for sort of long-term care, I think that's an open question. It can be effective for immediate safety. It can also cause more trauma for someone who's sort of involuntarily, staying in a hospital. You'll find most folks do say that it's a really traumatic experience when you're already having a really traumatic experience. So I think the question is, it depends. If you're trying to have homeless people not be on the street, if that's your objective, it probably feels really effective, but it's not a permanent solution for anything. It's really not, not answering the full question, the full distress.
Rachel, in terms of the effectiveness of community-based care, do we know whether a specific subpopulations will benefit from it? So it's maybe like people who are diagnosed early or people who probably have like fewer episodes. And has it been like shown in the literature, at least in global settings?
The effectiveness of community-based care. Yeah, we do know that for that idea of community-based care outside of the hospital is much more effective than let's sort of just using inpatient hospitalization. And we do know that things like the coordinated specialty care model for younger folks is a really effective in the holistic, a number of the services that it offers. So often they're including things like case management, including things like therapy and getting maybe reconnected to work or school. But it doesn't always answer some of those other systemic questions about how people get to those spaces. How can they access them? There are often barriers to insurance. You have many outpatient settings are clinical trials. So you have to meet certain requirements to be able to access them. And so there can still be these, if you can get access to the effective care or to the appropriate care, then it can be quite effective. The problems are getting the access to. There's some of those other, access points to that care. But the care itself, when it's these really intentional programs, are shown to be robustly effective.
So Rachel, as we speak, watching the news, and there's this whole, it's not necessarily in our psychosis, but there's this discussion of what do we do in schools, mental health support. And if you think that's the community where this vulnerable population, I suppose, of middle schools, what are your thoughts on how something like this approach could be adapted in school settings? I mean, the reason I said what's out there is right now, school shooting, is it the parent responsibility? Is it this, who's responsible, and everyone's waving their hands? So just wanted to get your thoughts on get adapted.
Yeah, I think the short answer is that we can all have a sense of responsibility. But I think embedding these kinds of services into schools has shown to be highly effective. If we think about community spaces where people feel safe and they feel secure, not for everyone, but that can often be a school setting. It's a place where people go regularly. It's not a stigmatized place. When we think about integrated care, we're thinking about care in places where people do feel safe. They're not feeling stigmatized. There's people around them that are familiar and that are continually a part of their life. And so schools become a really important component of integrated care because they are sort of another slice of health in a sense. And then in that way, you also get many other trusted folks who are kind of part of a solution or an opportunity for a young person. We often think about schools in terms of younger folks, but we have mental health services here on campus, right? Where people they're spending a lot of their time. It's a place where hopefully people feel safe. It's also a space where people are also aware of the other demands that students are living with. And so it becomes a really, hopefully an integrated, what you're working on there is part of this full picture of what you're working on as a person. And I think that's what we really want to think about in terms of health services. And also if there are places that you're already going and you're already feeling safe, it makes it much easier to access what it is that you might.
Have you, throughout your career, have you found that your definition of recovery comes easier to people with schizophrenia when they have the family support versus when they don't?
Without a doubt, yeah. And again, family can be defined in a number of different ways, but it's really a consistent group of consistent presence, yeah. Of unbiased support, of folks who are sort of writing that with you, and they're supporting you as you're trying out other new things. They believe in you, and they have that relational support is something. And there's a class in here at 1, so we're kind of wrapping up, but feel free to let me know if you have questions. Thanks for listening, thinking out loud, pulling ideas together.